Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Faisal Alfuways, R2 Restorative Resident. My pleasure today to present multidisciplinary seminar under title Bruxism, Causes and Treatment Options, supervised by Prof. Rol Al-Bunni. This is key articles. This is outline of presentation. Why I to select this topic. Many patients are not aware that they have bruxism. It's important to discuss the bruxism with the patient. Bruxism, grinding, clenching of the teeth, is a condition that was reported as early 600 before century with report of gnashing of the teeth in early texts. Bruxism is defined as repetitive jaw muscles activity characterized by clenching or grinding of the teeth by bracing or thrusting of the mandibular. Terms such as occlusal habit neurosis and neurologic traumatic have been previously used to describe clenching and gnashing of the teeth. Also, fairly to common to refer bruxism as parafunction activity, meaning the teeth and mouth are being used in the way that separate from eating, drinking, speaking. Bruxism in the literature and practice has typically fallen in two main categories, clenching or grinding during sleep or during the day. Some have classified bruxism as tooth grinding during sleep, while the proximania during the day. Proximania was first used in 1907 in peer-reviewed article in which Julian Delman suggests that bruxism could be linked to psychological factors like frustration and anger. Bodker also reported that grinding of the teeth was nervous manifestation, and he categorized two categories, nervousness and habit. Also realized that many patients with bruxism were not aware that they were grinding their teeth. Milton Love concluded that teeth grinding not only occurred during sleep, but during waking hours as well. Also able to define two symptoms bruxism: teeth are the sore, jaw are the tired when they're waking in the morning, sleep bruxism and awake bruxism. In regard to sleep bruxism, several severe symptoms have been reported, including TMJ pain, tooth mobility, excessive tooth wear, destruction of expensive dental restoration, degenerative joint disease. Awake bruxism is defined parafunction activity, including clenching and grinding of the teeth during the day. Awake bruxism has been linked to TMJ disorder, stress and anxiety, dementia. Prevalence according to Manfredian et al. 2013, although the prevalence of bruxism decreases with increased age, no significant bruxism between males and females. Up to 30% of adults report bruxism. Awake bruxism more frequent than sleep bruxism. Up to 40% of children experience bruxism, although that should be noted that parents report most cases of bruxism in children. Early intervention can be prevent dental problem and improve oral health. The review overall concluded that bruxism affect male and female equals and less commonly in the old people. The causes of bruxism has multiple etiology. Initially, it was believed that bruxism was caused by orofacial anatomy occlusal problem. More recently, psychological factors, sleep response, neurotransmitter are found to have stronger role in the causes of bruxism. Patients with a high stress lifestyle have strong relationship to bruxism. Patients who drink alcohol and coffee and use tobacco more likely to have bruxism. There is little evidence to support that drugs associated with bruxism. Bruxism show to be in the part of genetic. In children, secondhand smoke exposure and sleep disorder have strongest associated with bruxism. Risk factor for bruxism, stress and age, personality type, medication and other symptoms like use tobacco, nicotine or drink alcohol and coffee. Family members with bruxism and other disorder like Parkinson's disease or sleep apnea. The first step to diagnose bruxism, evaluate any change in the teeth and mouth over several visits, and required multifaceted approach including evaluation of patient psychosocial behavior, extraoral findings, the reporting of other symptoms. In order to definitively diagnose bruxism, polysomnograph, electromyograph should be used. Both of them used to measure activity of jaw muscles and not available in every office because it's very expensive. Sign and symptom, intraoral, extraoral. There are several signs and symptoms of bruxism. It's very common for a patient to be unaware that they have bruxism. It's important to discuss these signs and symptoms with all the patient. Ask patient if they clenching their teeth on dental history or exam form in one way to introduce the topic of bruxism with the patient. Intraoral like wear of the tooth, fracture teeth restoration, up fracture, loss of teeth, and detention on the tongue. It's important to note that tooth wear alone is not reliable symptom bruxism. Periodontal change may also exist, including widening of BDA, mobility, recession. The existence of these intraoral findings may indicate bruxism, but the presence of these findings does not give definitively diagnosis, as this complication can be caused by other conditions. Extraoral, like soreness of the jaw muscles, joint noises, TMJ, headache. Patient may also report soreness of the muscles of the jaw, especially masseter, lateral, medial pterygoid muscles. Patient may also report joint noises in TMJ. There is strong correlation between TMD and bruxism, although the exact relationship is unknown. Children do not experience the same relationship between bruxism and TMD. Children may show sign of bruxism but not experience any TMD pain. Adult patients often have headache-associated bruxism, though children do not typically report headache-related the condition. Symptoms related to TMJ and facial muscles are often common in adults but do not present in pediatric patients. Bruxism more frequent with mechanical than biological complication. This means the effect of bruxism can be easy to identify when the patient has compromised dental appliance than if they present with tooth wear alone. Bruxism and how to affect of natural teeth. In the early 20th century, Caroli recognized causal relationship between bruxism and periodontal disease. Several studies have concluded that bruxism may result in mobility, fracture, intrusion, extrusion, and open contact, erosion, pulp pathology. As bruxism is relatively difficult to diagnose, it can be identified by tooth or cusp fracture, obvious occlusal deflecation, TMJ disorder, sensitive teeth. Tooth wear has been shown to progress much faster in bruxer than bruxer. Fracture cusp or fracture teeth more frequent among bruxers. The relationship between clenching and cusp or tooth fracture is more easy understood when the focus is placed on the excessive force that can be exerted on the opposing teeth. Tooth mobility is typically caused by bruxism, is also considered in the patient treatment or through periodontoplasty and prostum. Specific to period, tooth mobility has been shown to cause open contact, food impaction, or accumulation of local irritant. Tooth mobility can be also affect post-orthodontic retention and stability, as well as unprotected endodontic treated. Cusp to cusp occlusion wear more easily than teeth with cusp to embrasure occlusion. For general object to treatment, reduce psychotension, treat sign symptom, minimize occlusal irritation, break neuromuscular and habits patterns. Treatment option for bruxism, home care. Patients have several options that may help prevent bruxism. Patients with the sore jaw muscles, apply ice or heat to muscles. Stretching exercise for the face and neck and shoulder may also help to alleviate or prevent muscles pain. Patients should be also avoid eating hard food or the food required a lot of the chewing and avoid chewing gum. Bruxism can be related to stress and personality traits. Another approach to treatment is through behavior modification. Biofeedback used to possible treatment with mixed results should be used with electromyograph measurement to measure muscles tension. During biofeedback session, therapist will be help the patient identify mental activity, relaxation technique that can be help regulate the body process to reduce bruxing movement. Other behavior approach that have been used: hypnosis, psychotherapy, sleep hygienist, behavior modification. In order to suggest appropriate behavior approach, a thorough history and assessment should be complete so appropriate behavior modification can be implemented. One common treatment recommended for patients with bruxism is occlusal splint. It is made of acrylic and site over mandibular or maxillary surface and indicate for patients with bruxism who also have tooth wear and show to reduce the wear of the tooth but have not been shown to eliminate bruxism altogether. Medical treatment. Bruxism patients have also had success with several different medical treatments, such as muscle relaxant, benzodiazepines, beta blockers can be used to treat bruxism. These medication may cause drowsiness and should be only used for a short period of time. The literature shows that is there not enough evidence to support medication as a long-term strategy for treatment bruxism. More recently, clinicians have used Botox to treat bruxism. It is applied locally at masseter muscles and causes muscle paralysis. Several studies show that those who receive Botox injection significantly reduced the pain related to bruxism, but did not reduce frequent of bruxism movement. It should be noted that Botox lasts only up to 19 weeks and has improved efficacy if applied frequent. The literature on Botox as treatment for bruxism is sparse and many of studies use small sample size. Clinicians should be approach the treatment carefully. Take home message: it's important to keep in the mind some basic principle for communication with the patient about bruxism. Using simple terminology is essentially in the communication with our patient. Educate patient about bruxism is most important part in treatment modality for long-term successful performance. And this is my reference. And thank you.